Hello, everyone. Good morning. This morning, I'm going to be talking about something I have not talked about before, calling it volume, the other uremic toxin, and I'll try to move quickly so I can give CC time to talk lots about mineral metabolism and see what's new there. Okay, so just as a brief overview, when we talk about consequences of kidney disease, we do spend a lot of time focusing on the metabolic consequences, the retention of toxic solutes and drugs, deficiencies of hormones and other solutes. And I'm going to here focus on something we may not spend quite as much time on, the dysregulation of salt, water, and electrolyte balance, specifically the dysregulation of extracellular volume in kidney disease. As a review, we are about 55 to 60% fluid, and that distribution of fluid is mostly intracellular, two-thirds intracellular, and the extracellular fluid is the one-third of our fluids that are outside the cells, 80% of which is the interstitial fluid. That's the stuff that's floating around cells and in muscle and tissue and everywhere else. And then 20% that's inside blood vessels. And given if you don't have heart, liver, or kidney disease, this extracellular volume is typically maintained in a very narrow range. There's been some additional work on sodium pools in the human body. The traditional view is that most sodium in the body freely equilibrates with water and the extracellular fluid, with some non-mobilizable sodium in bone and cartilage. Some recent studies using sodium MRIs have revealed that there is free sodium in tissues, in muscle and skin specifically, and that free sodium has the potential to be moved with dialysis or diuresis, and has immunoregulatory properties such that a high sodium diet can increase tissue sodium and increase immune signaling and contribute to chronic inflammation. We always hear that the statement, the progressive loss of kidney function leads to extracellular volume expansion. And we say that based on the idea that the kidneys are the central regulatory organ for controlling extracellular volume. But how much and how true is the statement in humans? And I think the first question to ask is how would you even measure? How can we even measure extracellular volume in a person? Is it possible to even measure how much is in this compartment? And the answer is yes, we can. The way it's done is you find a tracer that distributes within this extracellular fluid, and there are many. In fact, many of the things we use to measure kidney function, like iohexol, iothalamate, chromium EDTA, a lot of drugs, they distribute purely in the extracellular volume. So if you give a person a certain amount of, in this case, chromium EDTA, and you know how much you put in, and you're collecting urine along the way, so you know how much is coming out, and assuming there's no other loss or redistribution, if you wait for the EDTA to distribute and then draw a plasma sample, you can calculate the extracellular volume, which is the total amount that's still left in the body, the amount that you put in minus the amount that came out, divided by the plasma concentration, and that will get you the extracellular volume. That's obviously cumbersome. Many studies estimate extracellular volume using methods such as bioimpedance. This has gotten more and more precise over time, involves putting electrodes on the hand, shown in the picture, and also on the feet, and performing these calculations. I won't go into how bioimpedance works, but it's a way of estimating extracellular volume, and it's been compared with the gold standard, and in many situations agrees quite well. So back to this idea of the progressive loss of kidney function leading to extracellular volume expansion. This study actually quantified it by getting longitudinal gold standard measurements of extracellular volume by chromium EDTA. This is the NEPHROTEST cohort study, 1,500 patients with non-dialysis CKD of all causes. The GFR was about 45, and half were receiving diuretics. And over the longitudinal measurements, they estimated that extracellular volume increases by an average of 136 milliliters per year during CKD, with a 95% confidence interval of 106 to 167 mils per year. So it's interesting to think if extracellular volume is really increasing by about 130 mils per year over the course of CKD, and CKD typically lasts maybe 15, 20 years before dialysis, it would suggest that people who start dialysis with end-stage kidney disease are going to be pretty volume expanded by the time they reach dialysis, about 2 to 3 liters, in fact, if you calculate this out. And again, those longitudinal studies included many patients on diuretics. So this is including trying to stop the extracellular volume expansion that's happening during CKD. And in fact, that calculation agrees quite nicely with the results of this cohort study of 40,000 patients initiating dialysis across 26 different countries. The average age was 61 years, and they estimated extracellular volume using whole body bioimpedance, as we've talked about. Now, that's got some issues and some assumptions about its relationship to the gold standard that may or may not be met, but putting those aside, the average estimated fluid overload in an incident dialysis patient was 2.7 liters. Kind of agrees with this idea of slow progressive fluid expansion over the course of chronic kidney disease. But luckily, these lucky patients who have progressed all the way to dialysis and survived now get to go on dialysis, and we have a machine that will just take all that right off and put them right back to where they were 20 years ago, right? We can just put them, just take care of this problem right away. But no, that's not what happened. So in other studies, this is the largest cohort of maintenance dialysis patients. This is 8,800 dialysis patients across Europe. They'd been on dialysis for an average of 3.5 years. And again, they estimated extracellular volume by bioimpedance, and they're still very volume overloaded. This is post-dialysis extracellular volume, and they're 1.8 liters up still. And 66% had fluid overload, more than 1.1 liters. So not only does extracellular volume continue to expand over the course of CKD, but intermittent dialysis treatments do not adequately remove it. This is back to the tissue sodium story. This is a small study of 33 maintenance dialysis patients, 10 PD patients, and 119 controls. The patients had been on dialysis for 4.5 years for the hemo patients, 1 year for the PD patients on average. And you can see here that the muscle sodium stores and the skin sodium stores are markedly higher in patients who are receiving dialysis compared with controls. These were measured by sodium MRI. Okay, so there's all this volume overload in dialysis. The real question is, and the question I always had when I'd see legs like this, like in residency, was, hey, is this bad? And if it's bad, how bad is it? What are the consequences of having chronic extracellular volume expansion? So I think it's from a physiologic standpoint, there's enough data between association studies, animal studies, plausibility to make a causative statement to say that chronic extracellular volume expansion is a cause of hypertension. The vast majority of people, over 90% of people with stage 4 chronic kidney disease, have hypertension. The hypertension, we know, responds to volume changes, and the hypertension goes with a package. Chronic hypertension goes with chronic ventricular hypertrophy and then dilation of the cardiac chambers, both systolic and diastolic cardiac dysfunction, and pulmonary congestion. There's also associations of chronic extracellular volume expansion with mortality and hospitalization for heart failure and symptoms of heart failure. And those are association studies looking at volume overload based on bioimpedance with subsequent outcomes. So why don't we just take all this volume off? What's the problem? If ECV access is bad and we have a machine to take it off, why don't we just take it off? And there are still major barriers. Dialysis treatments are by nature short and intermittent, and the rate of ultrafiltration during these treatments typically exceeds the refill rate. I constantly am trying to tell fellows when I'm teaching that we have a catheter or a fistula, something directly accessing the blood intravascular volume of a dialysis patient, and we're pulling fluid out of this intravascular space at some rate. If and only if refill from the extravascular space keeps up, does blood pressure stay the same? if you're pulling fluid out of the intravascular space more quickly than it can refill from outside, then the patient will develop hypotension at some point. And that does not mean that that person is euvolemic in any way. They can be massively volume overloaded, but just unable to refill at the same speed that we prescribed. There's also this pervasive use of antihypertensive drugs that lead to the development of treatment-limiting hypotension before dry weight is truly achieved. And there really is an uncertainty about the seriousness of the problem. What's so bad about having an extra liter or 2 or 3 on board? It could be terrible, or it could be not so bad. And so we don't have enough clear data. And I think because this is a historical problem, we maybe downplay it to some extent. Oops, I just realized something. Oh, there we go. Okay. And this sort of summarizes how I think of the problem. We focus all the time with dialysis on this interdialytic weight gain. That as someone comes in, we ask how much they gained. We think we know what the dry weight is because it's written down on paper somewhere. We take that amount off with dialysis, so we pat ourselves on the back and say, great job. Interestingly, interdialytic weight gain has been slowly declining in the United States over about the past 15 years based on DOPS data. It's down to about 3% of body weight. It's been declining in other countries too. So it is possible with intermittent treatments to take the weight gain between treatments off in many, but certainly not all, patients. But of course, this ignores what I think is the underlying problem, that even when you come off dialysis, having your interdialytic weight gain removed, you're still volume up compared to where you should be. Normal people have their extracellular volume as low as it possibly can be, or just above that. And so we have dialysis patients have this extra bit here, and the consequences of that remain not completely clear. Certainly, having this extra volume is a cause of hypertension. And most likely, this extra volume contributes to cardiopulmonary congestion. I think it probably contributes to, to some extent, to symptoms and the ability to be mobile. Having edema or having extra volume on board, I think, just contributes to having dyspnea on exertion, or how far you could actually walk and what things you can do. And I think it really contributes to what I think of as vulnerability. When you have this extra couple liters of volume sloshing around, you get pneumonia, you get a viral infection, you get some other thing, you miss a dialysis treatment, you're just vulnerable to going into pulmonary edema, getting hospitalized, and getting very sick. So it's just this extra susceptibility. But we don't have all the data to prove that. Okay, so what about studies to get rid of extracellular volume excess in dialysis? So the initial studies are case series back from the 1970s and 1980s. And these series basically took patients who were getting usual thrice weekly hemodialysis care to much longer treatments. In the case of the Toxin experience, to 8-hour treatments, gradual volume removal, and always in the historical case series, withdrawal at the same time, parallel withdrawal of blood pressure medications, so you can get the weight down without getting hypotension during dialysis. These studies report just incredible results. In the CHARA study of 124 dialysis patients, all but one patient achieved normal blood pressure, less than 100, pre-dialysis systolic blood pressure, less than 140, without the use of antihypertensive medications. Other studies have reported other incredible results where you can completely control blood pressure with long, slow treatments and guided withdrawal of antihypertensive medications. We have to consider the very strong effects seen in these studies with what would be considered the most egregious methodologic flaws. Not even a comparison group. People are not even randomly assigned or even assigned non-randomly to get some kind of intensive treatment like this versus just usual care. Everyone the investigators just pick the patients they want to pick, and they put them on this regimen. Populations are not representative. The investigators, again, picked the patients they wanted. These are back in the 70s and 80s when the proportion of diabetic patients in dialysis was very small. They don't publish the protocols of what they actually did, and they ascertain the outcomes whenever they want. And so it's really hard. These things really limit the potential large, strong effects seen, but still, um, one has to be cognizant of how strong the effects of slow dialysis and withdrawal of blood pressure medications was reported. Okay, so since that time, dialysis became very protocolized, 3 times a week, rigid, and tied to funding. And so subsequent studies really focused on how can I reduce dry weight within the context of this regimented dialysis treatment. This is the first one. This is the CLIMB trial back in 2005, 440 adult patients getting maintenance dialysis, and they were randomly assigned to get crit line monitoring or usual care. And the crit line is detecting hemoconcentration. The instructions were to slow down the ultrafiltration if the crit line monitoring showed a large increase in hemoconcentration. However, very few of the treating nephrologists actually followed the directions. This is going to bring up a whole issue with studies like this, where they're trying to randomize people or assign people to some monitoring strategy. They then have to tell the treating nephrologist how to respond to that monitoring strategy. And many nephrologists don't really want to listen. They want to use their own, they have their own ideas about monitoring or managing dry weight. And so it's been tough for some of these studies to actually evaluate the impact of the intervention. So in this study, there was the crit line monitoring did not result in any change in dry weight or blood pressure or episodes of intradialytic hypotension. There was a paradoxical increase in hospitalizations observed in the study, but this was not seen in subsequent studies of devices or clinical management of dry weight. This brings us to the LUST trial, and this is another device. This is a device-oriented trial in which adult patients, hemodialysis patients in Europe, were randomized to either lung ultrasound monitoring or usual care to reduce dry weight. And this study, for a number of reasons, I think they wanted to get more outcomes, selected patients who had a, quote, high cardiovascular risk profile at the start. That is, they had a history of MI or decompensated heart failure. And they were randomly assigned to get this lung ultrasound monitoring every month. The instructions were if there were more than 15 lung comets, which are basically a variant of B lines indicating edema, the investigators were encouraged to lengthen or add ultrafiltration treatments and to monitor lung ultrasound weekly until there were less than 15 comets. And this is compared to usual care. Like other studies, what was found here is that being randomly assigned to the lung ultrasound group resulted in a reduction in the number of B lines, which was the target of the intervention. The number of B lines decreased from 15 to 9 in the lung ultrasound group versus actually increased in the usual care group. But the dry weight or the pre-dialysis weight didn't change, and neither did blood pressure. There were 62 composite outcomes in the lung ultrasound group versus 71 in the usual care group. The composite outcome was a composite of death, non-fatal MI or decompensated heart failure. And there were fewer episodes of intradialytic hypotension in the lung ultrasound monitoring group. But the difference in the composite outcome was not significant. One thing the trial did look at as a secondary outcome was episodes of decompensated heart failure, and they did find a large reduction numerically in decompensated heart failure episodes in patients who were assigned to the lung ultrasound group versus those in the usual care group. Again, this is a secondary outcome, not the primary result of the trial, and there's a small number of these events. However, it does bring up one of my pet peeves of many related to trials in nephrology, which is that you have an intervention, in this case, ultrasound, that's focusing on volume. You really want to focus on things that are directly downstream to that, symptoms, hypertension, things that would respond, heart failure, things that would respond directly. If you look at something like all-cause mortality as an outcome, well, there's so many things that affect all-cause mortality. volume, even if you had a treatment that was perfectly reduced extracellular volume back to normal, the most that treatment could contribute to an all-cause mortality outcome might be a relative risk of, say, 0.9. You would need thousands and thousands of patients to be able to detect that kind of that small of a relative risk. And so you're really stuck. You're not going to be able to detect a difference in, say, something like all-cause mortality in a study of a few hundred people when your intervention's targeting only one small slice of what contributes to all-cause mortality in dialysis. This is the DRIP trial, in which patients on hemodialysis were with hypertension were randomly assigned to a volume reduction strategy that was clinically motivated versus usual care. And so the clinical dry weight reduction strategy in this trial was pretty simple and somewhat harsh. They just would reduce your dry weight every session by 0.1 kilograms for every 10 kilograms of your body weight. So if you're an 80-kilogram person, every time you went in, your dry weight was reduced by 0.8. And they just kept doing that until you developed symptoms. And they did not change the length of the dialysis treatments or slow things down or change blood pressure meds. They did finally achieve some difference in dry weight. There was a 1 kilogram reduction in dry weight in the treatment group compared to the usual care group, and a 6.6 millimeter per mercury difference in blood pressure by the end of the study at 8 weeks. But there were more hypotensive episodes, as you can imagine, in the treatment group and more symptoms. How this balances in terms of contributing to overall patient health outcomes that affect how patients feel, functions, or survives, was not assessed. And then finally, we have our frequent hemodialysis network trials. Now, these trials really focused on reducing uremic toxicity by increasing the KT/V. So volume was not the focus, but still we can look in secondary analysis to get a sense of how these slow, intensive dialysis treatments affected things like blood pressure and dry weight in the modern era. These were just in the daytime trial. These were 245 adult patients receiving maintenance dialysis. The average KT/V had to be over 1, and the patients had to be able to tolerate intensive hemodialysis treatments. They were randomly assigned to 6 times per week in-center dialysis compared to usual 3 times a week dialysis. And the in-center dialysis treatments were relatively short. Even with 6 times a week dialysis, the total weekly dialysis delivered was just under 13 hours a week. So the sessions were just over 2 hours short. And again, they didn't specifically target volume in this trial. What happened in the study, though, in the patients who were assigned to the 6 times per week dialysis, there was a reduction in dry weight over the beginning course of the trial. These visits, V2, V3, V5, V10, 11, refer to the number of months after baseline. And so at 2 months in the 6 times per week group, you can see that dry weight has dropped quite considerably, already down by 1.3. And it stays down around 5 months, and then it goes back. In the 3 times per week group, dry weight does not change very much. However, when we look at blood pressure, the pre-dialysis systolic blood pressure drops right away in the 6 times per week group, sort of paralleling the initial reduction in dry weight. And it stays down over the course of the study, even though this group regained some of that weight back subsequently. So this idea of a memory effect or a lag effect of dry weight reduction helped inform my thinking about how maybe we should be doing trials in the future targeting dry weight in dialysis. Okay, so to summarize, the existing studies targeting extracellular volume excess in dialysis patients might not be the trials we all would want. They usually randomize people to some kind of device or clinically guided strategy that's tough to duplicate in practice. They exclusively focused on prevalent, long-standing dialysis patients, typically 2 to 3 years of dialysis upon enrollment. None focused on incident dialysis patients. They really achieved small differences in dry weight at best, up to 1 kilogram difference, even in the best light. And it's really tough to say what their impact is of these interventions on outcomes that relate to how patients feel, function, or survive. And so I think our barriers to treating ECV excess and dialysis remain the same before looking at all these trials, which is that we have short intermittent treatments where the ultrafiltration rate exceeds refill. There's pervasive use of antihypertensive drugs that limit volume removal, and we're still uncertain about how bad this is. How bad is it for a person to have 1, 2, 3, 4 excess liters of extracellular volume chronically? Is this something that's really making a large impact on their life or not? We have to figure that out. I thought after going through all this, if other people are able to do all these not so great small studies, why can't I do a not so great small study too? Take a crack at it. So this is a grant I just put in, see how things go, to target volume in patients on dialysis. I wanted to target patients initiating dialysis for the first time because no study has ever looked at them, and because this slow buildup of extracellular volume over the long course of chronic kidney disease provides a unique opportunity to jump in and get rid of all that volume right away. And also because studies suggest there's a potential lag effect. If you could treat the volume excess early, maybe you get some long lingering effect on blood pressure. So the inclusion criteria for this trial is incident dialysis within the first 8 weeks and hypertension with a blood pressure over 140/90. And people are going to be randomly assigned to thrice weekly dialysis, typical. If you're in the start dry group, which is the intervention group, you're going to get 2 extra ultrafiltration treatments per week. They're going to be purely ultrafiltrative treatments, purely convective, just volume removal, and combined with pharmacy-assisted de-escalation according to a protocol of antihypertensive drugs. And this is compared to being randomized to just usual thrice weekly dialysis. And yes, it's a burden to get 2 additional treatments of ultrafiltration per week, but the idea is to start dry. And this package of ultrafiltration and med de-escalation occurs for just 4 weeks, and then it's stopped. And so this is the sort of algorithm of the trial. In the intervention group, you get this extra 2 ultrafiltration sessions per week and de-escalation of the drugs over 4 weeks, and then stop. You go back to clinical management after that. Versus the control group, you go right to clinical management, and everyone's getting hemodialysis 3 times a week throughout. The outcomes of this study tried to pick ones that are proximally related to the reduction in volume, which is the 24-hour continuous ambulatory blood pressure, symptoms of heart failure and congestion, and ability to walk and do other activities that relate to function. Okay, that was pretty quick. I tried to go through as many of the studies as I could in the short time. There's many more small studies to talk about, and the topic is obviously very large, but I'll stop here, answer questions, and thank you for your attention.
Thanks so much, Bryan. Question from Raj.
Bryan, thank you very much. Very thoughtfully put together as always. Leah's comment actually is related. My comment is related to the comment that Leah put in the chat also. There are several thoughts that I have. The first thing is you shared the data for the FHN trial. There was a secondary analysis that was published on the impact of intensive control of blood pressure and volume with nocturnal dialysis, and that's the group which they had a more rapid progression to anuria. So much faster loss of residual kidney function. So that's a concern. In addition to that, there is this observational study that shows in people on hemodialysis that continue diuretics. So a call out to diuretics and optimizing diuretic management in people on dialysis. This is a large study from DaVita. Jenny Flight is the author that shows lower risk for that. And I know Nisha and Jenny have been toying with the idea of doing a trial in that regard. So allowed shout out if you were to residual kidney function and diuretic management as we try to optimize volume. Personally, I used to think that perfect euvolemia should be the goal 20 years ago. I am no longer there. I don't think there's a large group of people that require permissive hypervolemia. I just don't know how to describe that in an algorithm, but I know that when I see patients.
Yeah, I mean, just quickly, I mean, in terms of that last point, we'll find out and someday whether 2 to 3, having people having quote permissive 2 to 3 liters extracellular volume is making them feel terrible and not doing what they want to do and contributing to their cardiovascular death or not. Or it's not. I mean, we just don't know the answer to that question at this point, and we'll learn someday how bad that or how not bad that really is. I think we just don't know, and it's. Studies trying to look at the association of volume overload that show associations with all these bad outcomes are so hopelessly confounded. As best as job as they can possibly do, having excess extracellular volume in dialysis when people are trying to remove it is such a sign of ill health. It's only through randomized trials of removing the extracellular volume will we really learn the answer to your question, and we'll get it someday. There was other, let's see. Nisha, did you have a question? I saw your hand up.
I just put it in the chat. It's fine. Yeah. So yeah, this idea of residual kidney function, I do think we don't pay enough attention to this, and I think it's incredibly important. So we did put it in a clinical trial, which we are calling precision diuretic dosing, in which we're doing a run-in phase to find the right dose of diuretics for incident HD patients, and to help encourage adherence and use of diuretic therapy for volume management. And as you know, Bryan, like I think that volume management is critical in terms of hypertension and cardiovascular risk outcomes in this population. And in fact, the home blood pressure pilot study that we did, we found that even by shifting which blood pressure targets we're using, we were able to get people off of antihypertensives and really focus on dry weight reduction. And so, yeah, so terrific talk. I'm super excited you're interested in this. I'm really excited to hear more about this as this project goes on to, or hopefully if you are successful in this grant. There's an interesting kind of philosophy of protocolizing and philosophy of individualizing, and it seems like both are kind of aligned in saying whatever we're doing right now is neither of these, both can agree that what we're doing now is not quite right. But anyway, thank you so much, Bryan. We'll move on for time.